the Zane Quinn Center where we work in Toronto follows probably the most families in all of Canada, and we have a registry. And one of the reasons we wanted to do this was to, first of all, give back to all of our patient partners who we work so closely with to give you updates on this ever-changing syndrome because I think that's helpful and important. And also to thank you for being part of the registry, for those of you who are part of the registry, because we only learn when we do research together. So some of the information that Dr. Gilad is going to present is part of the research that our team in Toronto has helped contribute to, which means all of you helped contribute if you have agreed to research, which is, I think, a good thing for updating you. So this night is only for our families with CDH1 and ctNNA1 variants and their caregivers and some genetic specialists like Tom, who's my co-counselor at Mount Sinai, and Kara. And we are incredibly excited to have Dr. Gilad talk to us about some of the research that he's been involved with. He's a gastroenterologist at the University of Chicago. He has a special interest in hereditary gastric cancer and has led a very big multi-institutional, multi-nation, because now Canada is involved in the study, group to look at specifically screening in hereditary gastric cancer. So I'm going to turn it over to him so that he gets a chance to do his talk, and then hopefully we'll have time for questions after he's done. So over to you.
All right, thank you very much, Melissa. And I want to echo exactly what you said. None of this would have been possible if we didn't have patients who are um, being a part of large registries that help us understand what's going on in hereditary cancer syndromes. These are rare diseases and rare syndromes, and we need a lot of information in order for us to figure out what's if we're doing things right or what can we change to make our the way we take care of hereditary cancer syndrome carriers better. So really, thank you everyone for being part of the registry and helping us advance the field. So I'm going to talk about hereditary diffuse gastric cancer syndromes. I'm going to talk a lot about, going to mention a lot of mainly CDH1, and I know that there are maybe CTNNA1 carriers in the audience. We're not going to neglect you. It's just that we know most of the data today from CDH1, and we're going to touch a little bit about CTNNA1 as well. Don't worry. So without further ado, how do I move this? Okay. So I have no relevant disclosures for this talk. The agenda for today, we're going to start by talking about the biology of hereditary diffuse gastric cancer very briefly. We're going to talk about the cancer risk estimations and how these have changed over the years and how they have changed the management guidelines that we have nowadays. We're going to talk a little bit about what do we know about endoscopic surveillance and what kind of evidence we have. And as I said, I'm gonna say CDH1 for the majority of the evening, but I'm gonna specifically talk about CTNNA1s CTNNA1 at the end to tell you what do we know about that specific variant, that specific gene, and then we're spearheading the gastric consortium. That's the multi-center international collaboration that we have on CDH1 patients. So I'm going to give you a little bit of results from what we know from that study. So hereditary diffuse gastric cancer, the name is now changing to hereditary diffuse gastric and lobular breast cancer, which is a mouthful. I'm not going to say that throughout the night. It's an autosomal dominant cancer predisposition syndrome. That means that we have two copies of our genes from our parents, one from our mom and one from our dad, and we need just one copy of the gene to have a mutation in it in order to manifest hereditary diffuse gastric cancer. It is estimated to account for about 1 to 3% of all gastric cancer, and it is caused by pathogenic variants in the CDH1 gene or the CTNNA1 gene. It has other features like increased risk for lobular breast cancer and also associated with cleft lip or cleft palate. The reason that you're seeing this statue in here, this is a Maori statue from New Zealand, is because the disease was first diagnosed at the or first identified at the end of the 1990s. In Maori families in New Zealand, they were the first families to be described. CDH1 encodes for a protein called ecadherin, and CTNNA1 encodes for a protein called alpha catenin. The ecadherin is a cell adhesion molecule, as you can see here. What it does is it is important for adhesion between two cells. And that also tells the cells where's up and where's down, and what and where should the cell has polarity. It has an upside and a downside, and it tells it where exactly it should face. And when ecadherin is not being produced properly, the cell doesn't know where it is, and it kind of loses orientation and starts wandering off to other places where it shouldn't go. It is also involved in signaling pathways together with alpha catenin, which also affect cell proliferation and without control can lead to cancer. The hallmark of the disease, or of the syndrome, it's not a disease, is the signet ring cell carcinoma, which is this large balloon-shaped cell that is filled with mucin that pushes the nucleus of the cell into the side, giving it the shape of a signet ring, hence the name. Now, signet ring cells can be either localized in the gastric lining to the most superficial layer called the mucosa, where it can remain dormant for many, many years or forever. And we consider this to be the localized form of signet ring cells. In some cases, some of these cells get a signal that causes them to become more invasive and more aggressive and invade further into the stomach lining. The problem is we don't know what kind of signals we're talking about, and which individuals will develop the more invasive or aggressive phenotype. So previous recommendations recommended that every patient who carries a CDH1 mutation should undergo a prophylactic gastrectomy, and surveillance with endoscopies was only reserved for individuals who didn't want to undergo surgery or wanted to delay it a little bit. Guidelines come out every few years, and an update in 2015 didn't change a lot. But these guidelines were based off of high risk estimation for gastric cancer. And what you see here is the risk estimation by age 80 for male and female patients from the earlier studies about CDH1 carriers. And you see that the risk was estimations were pretty high, between 60 and 80%. This was the reason that we recommended to have the stomach removed for most patients who carry CDH1. But these studies were based off of what we call highly penetrant families. That means families that have a lot of gastric cancer in them, which makes themselves known because it's a lot easier for us in clinic to identify a family who might be at risk when there's multiple of cancers in it. However, there's a lot of families out there that have a lot less gastric cancer in them. And as more information came in and those families were identified, the risk estimations went down significantly, somewhere between 25 and 40% lifetime risk. And the most recent study that came out of a multi-center collaboration at the NIH noted that the risk may be as low as 7 to 10%. Now, because the risk estimation changed, there was also a shift in the recommendations that came out in 2020. And this was the first time where we incorporated family history into our decision making. So whenever someone was diagnosed with to carry a CDH1 mutation, we asked whether or not they have a family history of gastric cancer. If the answer was yes, the recommendation was once again to have the stomach removed. If there was no stomach cancer, then endoscopic surveillance was deemed to be reasonable, and gastrectomy was recommended if we find those signet ring cells, the hallmark cell of the disease, on upper endoscopy biopsy. But that raised another question. Nearly all patients that have their stomachs removed are found to have signet ring cells. If we take out 100 individuals and take out their stomachs prophylactically as a risk reducing procedure, we'll see those signet ring cells in up to 95% of gastrectomy specimens. And some people say that the number is probably closer to 100%. It's just that we don't give the pathologist enough time to go over every single micron of the stomach. But we just said that the lifetime risk is somewhere between 10 to 40%. So what happens to those 70, 80% of the rest of the people? Well, many of these individuals who have these cells will have, in many of those cases, these cells will remain dormant throughout a patient's lifetime. And furthermore, having surgery is no easy thing. This is a life-changing event that can have a lot of morbidity associated with it. And I'm not going to go over the entire list, but almost all individuals experience weight loss to up to 20% from their baseline, nutritional deficits, and osteopenia or osteoporosis. That's not to say that surgery is not the right choice in some cases. It's just that in this day of age, we're trying to personalize our management of individuals, and maybe surgery is not right for everyone. Which, after we saw that, there was a question whether or not endoscopy for everyone is, including those with signet ring cells, is the right way to go. So, what do we know about the effectiveness of endoscopic surveillance in hereditary diffuse gastric cancer? To talk about this, we need to first describe what we do when we do endoscopic surveillance. So we do an upper endoscopy. I'm assuming a lot of you have already had that. We put a scope through the mouth. We go into the stomach. The first thing that we usually do is insufflate and deflate the stomach to see that the compliance, the way it insufflate and deflate, is okay, and there's no rigid areas that are not insufflating, which is a little bit concerning. Then we take a very good look at every part of the stomach and look whether or not we are identifying any worrisome or abnormal looking lesions, and we take targeted biopsies of any lesion that we find. And after that, we take random biopsies from multiple parts of the stomach. The most common protocol that is used was created in Cambridge in the UK, and it's called the Cambridge Protocol. But there have been other protocols in the past. Another one that was very common was the Bethesda protocol that was introduced by the NIH. This was mainly experimental. The Cambridge Protocol takes about 30 random biopsies. The Bethesda protocol subdivides the stomach into multiple areas, about 40 areas, and takes about 90 biopsies. Now, it showed more signet ring cells, but the outcomes at the end of the day were pretty much similar. And the downside is when you take a lot of biopsies, you're also causing a little bit of scarring tissue to be created, and it makes it more difficult later on when you go into your second, third, and fourth endoscopy. These little scars, they add up and makes it a little bit difficult to visualize the stomach. So we're moving away from the Bethesda into Cambridge, and there are some people who are actually asking, do we actually need to take the random biopsies, and why not just do the targeted biopsy, which is a whole discussion of itself. It's important to remember that the goal of endoscopy is not to detect every single signet ring cell carcinoma focus in the stomach. We know that those foci are there. They're not surprising anyone when we find those. The goal should be to try to find ways to exclude deeper infiltrating lesions when the signet ring cells are invading deeper into the deeper layers of the stomach, the submucosa and beyond that, which is not as easy as I might make it to be, because when we take biopsies during endoscopies, we're scratching the surface. We're only looking at the superficial layer, and it's difficult to say when there's invasion just by looking at superficial biopsies. The second goal is try to detect whether or not there's large or numerous foci of signet ring cells, which also haven't been proven whether these are worrisome features or not. If someone has multiple lesions, it's a question whether this is a more concerning finding. We still don't have data about that. And probably the most important thing that we do during endoscopy is try to assess whether there's any change in the histology, or more importantly, change in the endoscopic appearance of the stomach that might suggest that there might be a more malignant behavior to the tumor. These are some of the things that we're looking for when we do upper endoscopies. They include these white pale spots that can be found throughout the stomach. These are known to be um, the most common lesion that has signet ring cells in it. Not necessarily the invasive type, but it is associated with finding those cells. There's thickened folds, something called linitis plastica in Latin, which is basically means it looks like a water bottle that made out of leather. And you can compare the how thick these folds look compared to the ones on the left. And erosions and ulcers that are also something that we're looking for. And if there's signet ring cells in them, in these lesions, it's a little bit more concerning for a more deeper invasion. So what do we know about the outcomes of surveillance? Well, there are two large prospective studies came out in 2023, one from Cambridge and one from the NIH. It is important to note that both of these studies are from expert centers that are dedicated to CDH1 patients, or have a department, or have individuals who are dedicated for that. They have pretty short follow-up on these patients, between 30 and 50 months, which makes sense because before these studies started, we didn't recommend surveillance for patients and everyone would have their stomach removed. That's why we don't have long-term data yet. Hopefully that will happen in the future. And these are cohort studies, meaning these are not randomized controlled trials. It's not ethical for any of us to tell patients, you're going to surgery, you're going to surveillance. This is something that patients decide with us, and are not being told to do something. So some patients self-select because of some prior history, whether or not they want to undergo surgery, which might affect the results. And in these studies, about a quarter to 36% of patients decided to undergo gastrectomy. I'm just going to go over the results of the NIH study. I'm not going to, because it's the largest of the two and the more recent one. They followed 270 CDH1 carriers, eventually 120 continued surveillance at the NIH, including 51 individuals who had signet ring cells identified. Again, I'm reminding you, these are individuals that in the past, we used to tell them that they need to have their stomachs removed. Two individuals during surveillance were found to have visible lesions in their mucosa that had signet ring cells in them, and they were recommended by the physicians in the NIH to undergo therapeutic gastrectomy. And both these individuals were found to have a more advanced cancer, which was stage 2, when it was very much surgically removable and treatable. And both these individuals are doing well to this day. 74 individuals were found to have signet ring cells, and the majority of which, 58, continued surveillance, and another 44 had normal EGDs, upper endoscopies, and 33 continued surveillance. None of these individuals, after a follow-up of 3 years, had any invasive cancer, and no one in this study, albeit it was with a short follow-up, no one developed any metastatic cancer, and there was 0 death from gastric cancer. So all of these data caused a change in our guidelines in 2025. The NCCN is the National Comprehensive Cancer Network. That's one of the main guidelines that we're following here in the US. And they recommended that endoscopic surveillance may be offered to individuals who do not have any high-risk signs or symptoms, which may include significant weight loss that is unintentional, early satiety, meaning getting full very early, unexplained anemia or abdominal pain, or any worrisome endoscopic findings like these thickened fold masses or large ulcers that we can find. It is important to note that we are not completely sure what are the high risk features are. Um, these are expert opinions at this point. We don't have any good evidence that says exactly what are the lesions that we need to look for and what are the and what which lesions are probably okay and can continue surveillance. And that's what some of our studies aimed at. Let's start talking a little bit about decision making in CDH1 and what makes people decide to undergo surgery and what makes people decide to undergo surveillance. You can see in this forest plot, there's on the left there are a few categories. People who are on the left side of this line here are people or categories that or variables that are associated with patients deferring surgery and undergoing surveillance. And on the right are categories or variables that are associated with patients' choice to undergo surgery. So older age was associated with delaying or deferring surgery, which makes sense because we don't recommend when someone is diagnosed at an older age to undergo surgery because most of the risk is behind them at that point. Male sex was associated with deferring surgery because men procrastinate. Surprise, surprise. And also time to decision. If the people are procrastinating and taking their time, they are less likely to eventually undergo surgery. On the other hand, if there was a strong family history of gastric cancer or there was a death of a relative due to gastric cancer, these individuals were more likely to decide to undergo surgery based on personal experience. And also, when signature cells were found on upper endoscopy, that was also associated with the decision to undergo surgery, partly because that in the past our guidelines recommended this, but also in our experience, a lot of people feel like this is becoming real once they find the signature cells, and that at that point that they decide in many cases that they want to undergo surgery. So what do we do here in Chicago when we're talking with our CDH1 carriers? Well, we talk about both of these options and these are some of our consideration where we're talking about each of those options. So for patients to undergo gastrectomy, we recommend this to patients who desire zero risk of having overt cancer. We talk about risk tolerance. Individuals need to understand that there is risk continuing surveillance, and we cannot say that the risk is zero. And they need to understand and accept this. And if they don't want to, then probably gastrectomy is the better choice for them. Those individuals need to be healthy enough to withstand major surgery and understand the possible complications that are associated with surgery. When we talk about endoscopic surveillance, these individuals need to have no worrisome clinical, endoscopic, or histologic features on their endoscopy. They need to understand that while the risk estimations are lower these days, they are still higher than the risk of developing gastric cancer in the general population. And most importantly, they need to be willing to undergo at least annual surveillance. If there's any concern of them not being able to continue follow-up for insurance issues because they live far away, then it's probably unsafe to undergo endoscopic surveillance because we might not be able to capture this in time, and gastrectomy should be discussed in those cases. The most important thing is to not rush anyone. There's usually no ticking time bomb in the background, and usually patients have enough time to discuss this amongst themselves, with family members, with providers, read about it. We always offer them to connect them with individuals who had gastrectomy or individuals who decided to undergo surveillance to hear about their experience. We also recommend that there's involvement of a multidisciplinary team that includes a gastroenterologist, genetic counselor, surgeon, dietitian, and we also we offer everyone to meet with one of our oncology psychologists to discuss this because it is a big decision to make. And this should be done in expert centers that have expertise in dealing with CDH1 or hereditary diffuse gastric cancer patients. What about CTNNA1? Well, the majority of data that we have nowadays is from studies that are looking at CDH1 patients. And we are today, I'd like to think that we are today where we were about 10 years ago. We are today in CTNNA1 where we were 10 years ago in CDH1, meaning that the data that we have available right now is from those highly penetrant families that makes themselves known because there's a lot of cancer and it's easier for us to pick those family up, and these affect our risk estimation. So the first study that came out in 2022 that was a collaboration of European and American centers showed that the risk of gastric cancer is somewhere between 49 and 57%. And this was based off of 46 carriers from 16 families, not large numbers. And again, these were highly penetrant families. But there was a study that came out last year, and actually Melissa is one of the authors on that one, that used molecular, clinical, and population data and compared the risks of CDH1 and CTNNA1, and it actually showed that the risk of gastric cancer in CTNNA1 carriers is fivefold lower than that of CDH1, and the risk of breast cancer is eightfold lower than that of CDH1. So the truth is probably somewhere closer, is probably somewhere in between. But since the original studies in CDH1 estimated the risk to be at about 80%, and the initial studies in CTNNA1 estimate the risk to be at about 50, 60, it's probably going to be lower as more information comes in. A little bit about the Gastric Consortium, who we are, what are we doing, and what are some of our results. So Gastric stands for Group of Investigators Striving Towards Research in CDH1. I am not the one who made that name up. That's Bryson Katona from University of Pennsylvania, and I take no responsibility for the name. We're a collaboration of currently 13 centers in North America, including Toronto, that are sharing data, de-identified data of our CDH1 carriers, their outcomes, with the hopes of trying to identify what are the lesions that are concerning and what are some of the characteristics of patients who develop the more aggressive or invasive diseases. We are also interested in doing a penetrance analysis or risk estimation in a very large cohort that we have. And our third goal is to see what the post-surgical outcomes are of individuals who undergo gastrectomy and try to see if we can kind of unify the way we are following patients, because right now every center is doing something different at this point. So some initial results that we have are CDH1 cohort contains 390 carriers, which is the largest number to date. The average age of carriers is 44 years, 63% are female, and we had about 4% of our cohort that had metastatic disease diagnosed, identified at their diagnosis, which is how they came to be diagnosed with CDH1. We also had 338 individuals that had at least one upper endoscopy, which is 90% of the cohort. And overall, we have 735 upper endoscopies overall. And in these endoscopies, 95 individuals were found to have signet ring cells. It's about 30% of our cohort, which is in line with previous studies. 60% were found to have those signet ring cells on their first endoscopy. And of those 95 individuals, 25% decided not to undergo surgery, and none of these developed any advanced cancer. It's also worth noting that we had about 177 foci identified. The majority are found usually with random biopsies and only about 15% with targeted biopsies. And most of these are found in the more proximal parts of the stomach rather than the distal parts, which is also in line with previous studies. Regarding our surgical outcomes or surgical data, we had 196, 52% of our cohort underwent gastrectomy. Of these, 18% were found to have no signet ring cells identified on their gastrectomy specimen. 70% had the localized disease, meaning only the T1A, where those signet ring cells are only in the superficial layer of the stomach. And we had 11 patients, 5%, that had more invasive disease. When we tried to, moving up, when we tried to find features that are associated with the more invasive or aggressive phenotype, we saw some of these endoscopic and histologic features that are down in the bottom here, and I'm not going to go into detail about each and every one of them. What you're seeing here, the two columns, the gray column is the positive predictive value, and the red columns are the negative predictive values. What that means, a positive predictive value is if we get a positive test results, what are the chances that that individual actually has the disease? And as you can see here, the numbers are pretty low. That means that we had these features were found both in individuals with advanced disease and also with localized disease. But what's reassuring or encouraging is the red bars, the negative predictive value. What that means is if a test is negative, what are the odds of that individuals to actually not have the disease? And the numbers are very high, 95, 96, 100%. So the reassuring thing here is that if we don't see anything on the endoscopy, there's a very high likelihood that there's no invasive disease present. And that's one of the outcomes that we had from our studies. We also talked about doing our own risk assessment because we have the largest the largest number of individuals and family members in our cohort. We have about 7,500 individuals and their family members. So our numbers, our risk estimations are slightly higher than the ones that were published from the Ryan study from the NIH 2 years ago. That's not this. I don't think that number should discourage anyone. The numbers are still lower than initial estimations and are still lower than the previous two studies that came out in 2019. And it just shows that when you take different populations, you might see different risk assessments. And it's not changing anything about our practice. We're still talking about endoscopic surveillance and gastrectomy and offer both of these options. And I think these numbers are making us more vigilant to the fact that CDH1 carriers can still develop gastric cancer, and it's important to keep a good eye and be on our toes and make sure we're not missing anything. So I think that it's important for me to make sure people are not discouraged by these numbers. So to summarize, the cancer risk in CDH1 and probably CTNNA1 carriers is lower than previous estimates. There is a shift in paradigm, the shift in the HDGC management guidelines. And nowadays, not every CDH1 or CTNNA1 carrier needs to undergo prophylactic surgery. It is important to remember that the goal of endoscopy is not to identify every single signet ring cell, but to identify when a person develops the more invasive phenotype. And we still need some tools for risk stratification and identifying who are the individuals who need to undergo gastrectomy and who are the individuals who can safely undergo endoscopic surveillance. And more research is still needed from multi-center consortia. And it's important to remember that shared decision making is the cornerstone of talking with patients who carry CDH1 variants, taking into account the pros and cons of either endoscopic surveillance or gastrectomy. And with that, thank you very much, and I will take any questions. Let me stop sharing.
Thank you so much. That was great and such a good review. I was thinking before this started that we have people on here who probably were diagnosed 20 years ago and people who were diagnosed a month ago, and the counseling has really, really changed over the years. And a lot of that is because genetic testing has become so much more widely available that there are families that come in that don't have any gastric cancer, and it's really changed our risk assessment. We didn't know CDH1 could be in a family with no gastric cancer. So now we know that, and it changes the risk and the screening and our advice and everything else. Um, so I think that's really great. I think if anyone has questions, maybe you could raise a hand and we'll look at it, or you can write a question in the chat if you don't want to ask it out loud, and then we'll just keep an eye on who has questions that they want to ask. Um, and I'm just looking to see. Okay, no, do you want to ask a question, Nosheen? You can unmute yourself if you like, or you can type it in if you want. I can't hear her, so let's see. So the question is, can you explain why the numbers are so much higher than the Ryan, I'm assuming the Ryan study with Jared
Yeah,
and Davis? Yeah.
that's $1 million question. And we have epidemiologists on our team that were asked the same question. So there are a few explanations. There's some minor differences in the methodology. It, if you're looking at the same data and apply different statistical methods, you might get different results. We used generally the same statistical method they used with slight variations, and we're now changing those a little bit to see if we get the results different. But I think mainly the main the main reason is that our population that was followed is different. We have so let me tell you how we did the penetrance analysis, the risk estimation. There's pedigree data. There's data from data from family trees that we collect, and we try to figure out which patients carry CDH1, which individuals in the family tree carry CDH1, which ones developed cancer and at what age. And we are also, the important thing is trying to remove those who were found to have just the superficial signet ring cells, because we don't consider those to be overt cancer, because we know about 95% will carry those. And the the statisticians and epidemiologists then introduce a modeling system that takes into account previous estimations, and as we introduce the data into it, the risk it's refining the risk estimation of the model. The families in our consortium, in our pedigrees, had about 400 documented gastric cancers, and the ones in the Ryan study had about 100. We also had about 7 individuals who had genetic testing done in each family, and they had only 6. So we had families that have a higher number of cancers compared to what was found in the Ryan study, which is from the NIH. It's important to remember that the NIH study had 4 centers in it, but the largest center that contributed the families was the NIH itself. They had about 200 families, and about 150 were from the NIH. So their numbers affected the results significantly, while our numbers are more distributed throughout the continental United States and America and Canada. And people who are going to, and there might be some sort of selection bias towards the people who are who were followed at the NIH in the past compared to those who are being treated locally. Some people who are able to fly to the other side of the country might have different risk estimations and might have different results than the ones who are being treated locally.
I think also it's important to remember in the Ryan study and the NIH study, they did have different graphs